Good morning. This is video 17 of the Tulip Airways series, and this video really is all about reframing Tulip as what it's supposed to be. I've presented it previously as a device that was capable of saving patients' lives, or certainly preventing a cricoid thyroidotomy in at least 3 cases, but I think I need to explain the main objective of Tulip, which is to ensure greater safety so that the anaesthetist, the airway provider, doesn't find themselves in trouble in the first place. So let's just go through that. That's the Tulip Airway, as you know, different sizes, 5 different sizes, headbands, no headbands. Okay, I've previously spoken about risk reduction. Now, airway deaths tend to happen not because the user, the consultant anaesthetist, lacks skill. It tends to happen because decisions are limited by the availability of current equipment. So if difficult airway society plan A, B, C all fail, an Guedel mask fails, an LMA and an iGel fail, and attempted intubation fail, what then happens is largely damage control rather than actual control. So the core problem that I think exists is cognitive, right? So it's not technical. We're taught that airway management is a series of dexterous skills, but airway failure isn't a technical problem as such. It's a decision problem. Which way do you go when you find yourself in danger? So the real danger isn't the laryngoscopy. It's the kind of just before that, when the clinician is forced to make a speedy choice in an attempt to protect his patient. So what happens is that when you find yourself in trouble as an anaesthetist, the discussion in your head is, what am I going to use? Am I going to use a laryngeal mask, an iGel, an ET tube? Am I going to wait to see how things happen, or do I need to move now? And then there's quite a critical decision. Do I deepen anesthesia and go for intubation, or do I abort, let them wake up? What am I going to do? Am I going to push forward? Am I going to escalate? Am I going to de-escalate? However, that entire series of potential options are a series of false forks, because it doesn't really matter what you do. Things are likely to get worse and the risk kind of rises immediately. Now, this is what happens. I mean, even to the most experienced of clinicians, in situations of, extreme danger for the patient, they become indecisive, not because they lack skill, because they actually know the cost of what will happen if they get this wrong, right? The patient is becoming more hypoxic, consciousness is fluctuating. If they're already unconscious, then in under anesthesia, then you have a few more options. But basically, in a situation whereby you can't make a patient breathe, things get quite hairy quite quickly. And then if nothing works, if a Guedel mask doesn't work, an iGel doesn't work, an LMA doesn't work, an ET tube doesn't work, if a laryngoscope doesn't work, then all of a sudden you are very much on your own. I mean, what algorithm after that? So the critical insight, as far as I'm concerned, is a bit of an uncomfortable truth. Is the people who die from airway problems actually didn't need rescuing in the first place. What they really needed to do is be stabilized with a piece of equipment that can actually do the job effectively, and for this to happen before the panic. So rather than thinking of Tulip as a rescue device, I would suggest that you actually think of Tulip as the first line choice of what you're going to do in the first place, so you don't find yourself in difficulty in the first place. So I want to reframe Tulip now. It's not a rescue device, right? It's for all first-line airway interventions, all ABC, all CPR, starved elective anesthesia, before and after intubation, intubate through it, bronchoscopy, endoscopy, upper GI scopes. So what Tulip really is it's supposed to be the most basic, fundamental and effective airway that you can get hold of, whether you're a nurse, whether you're an 8-year-old child, whether you're a consultant anaesthetist, whether you're a paramedic. And the idea is that the patient doesn't need rescue in the first place. So rather than using a Guedel mask, moving to a Tulip, LMA, moving to a Tulip, if you start with a Tulip, it won't need rescuing. So in part of this reframing attempt, basically, if the TULIP has already been proven to save at least 3 lives in a situation where, you know, an eye gel, an LMA, a Guedel mask, and even a video laryngoscope have failed, and that's happened 3 times by now, and you've seen that probably in other videos, then I'm going to ask you, what difficult airway protocol? You know, what happens to Difficult Airway Society Plan A, B, and C? Now, this is what TULIP actually does, right? It takes out that false fault. There is no Guedel mask, there is no eye gel, there is no LMA, there is no ET tube at this stage. But what it does is it allows immediate airway control even if the patient is semi-conscious. So you don't have to deepen the anesthesia. You know, you can allow the patient to recover and protect the airway while doing that. You will have stable ventilation, but you don't need paralysis, right? Now, nothing else can do semi-conscious other than a TULIP. A Guedel mask can, but it's intermittent and you could lose the airway. So what a TULIP will do is preserve consciousness and reflexes and not work against the patient. You can ventilate. Once you have airway effective control, you can choose what to do. You can wake them up, or you can allow them, you know, deepen the anesthesia. But this is the moment of decision. When you're finding yourself in real trouble, you know, perhaps you should have been using a TULIP in the first place. Because if you do use a TULIP in the first place, we've found that basically the most difficult question completely disappears, right? The consultants are no longer asking, you know, do I need to escalate now? What they're asking is, you know, what do I do now that the patient is stable? I've got airway control. And that is control. That's not rescue. So if you use a TULIP in the first place, what rescue? So, but look, and we've discussed ENT situations where you don't need to intubate with a TULIP, you know, when you're using a TULIP because of the airtight, blood-tight cuff at the oropharyngeal level. So basically all the blood is up there for dental, nasal, oral septoplasty and the like. But look, this is not an attack on intubation because we need it. We know that, you know that, I know that. So basically it's a case of what it does is it's an attempt to remove intubation as the only way, right? The default position, the preset, I've got no other choices other than intubation. Well, that's not true anymore. Right? So what you can now do is you can make a considered decision as to whether or not that intubation is necessary rather than it being driven by kind of an intense fear of damage and, you know, inhalation, aspiration, you know, hypoxia and the like. Okay, hypoxia is what kills, right? So what a TULIP will do is basically stabilize. It'll allow you to, you know, optimize the patient while making a decision. So, you know, you can have a glug on your coffee if you're, you know, if you've got a TULIP in place. So decisions aren't rushed, you know, it's not a catastrophic cascade, let's put it that way. So errors don't happen. But look, this is the whole point, is TULIP, you know, is not here to save people after failure. But of course, you find yourself in failure, use a TULIP, please. What TULIP is here to do is to prevent that failure in the first place, right? No panic. Now, you've read in some of the consultants who in the reports that you've seen, they used the word panic, and then they used TULIP, and there was no panic. So, in summary, this is not about replacing your skills, right? It's taking you years to use them. You know, it is as much about the airway user as the airway, as far as I'm concerned. But it's what it is about protecting my, you know, my brothers and sisters in healthcare, the paramedics, the nurses, the doctors, you know, whoever gives a damn, being, you know, forced into choices that are largely impossible, because with the TULIP you don't need rescuing in the first place, and if you do, you can intubate through it, you can use a scope, you can use an orogastric tube, do what you like. But in terms of like your potential chance of success and survival, you know, safety, success, survival, that is the whole point of TULIP. So look, everything you need, the evidence, you know, the clinical trials, the videos that I play, they're all on the YouTube. They're all on the YouTube channel that you're watching now, of course, but they're also on the Age of Aquarius website, which goes into probably more detail than you bother to read. But that's the point of TULIP. Use TULIP, you probably won't need rescue.